There's so many non-healthcare people that are simply pushing these random supplements, trying to get commissions on them, and using confusing terminology, using wrong facts to trick people into taking things that are most likely just not doing anything, but could be dangerous.
Welcome back to another episode of the podcast for doctors by doctors. I'm Dr. Michael Jerkins, joined by my co-host, Dr. Ned Palmer. Ned, how's it going?
Cold. Can't handle it this winter, Michael. Yeah. But I'm gonna survive.
What, you live someplace that's cold?
It's shocking that Michigan is cold. That is true. That is true. But we're gonna survive. How are you doing, Michael?
I am cold, but in a different way. In Arkansas, it just isn't the same as Michigan, it turns out, in lots of ways, probably. But temperature is one of them. I will say it did snow and we did sled, and I was proud of myself. I built a snow ramp made out of snow for my children and other neighborhood kids to potentially break a bone. There were
Yep.
no bones broken, I can say.
What an interesting way to assure job security as a pediatrician than to build a snow ramp. You might as well be a pediatric ortho.
Well, it is funny though, because a lot of people from the neighborhood came to sled, and there was a dentist in the group and a pediatric surgeon. So I felt like we had our bases covered pretty much.
That's true. You were also, if the videos that I saw were all true, you were sledding down the street, which also raises certain safety issues that I wanted to.
Well, there were adults that were scattered about the street that were
Okay.
fighting cars, and it was super icy. No car was going up and down.
We're going
Everyone was
up that
taking
hill.
stuff.
Okay. Okay.
Yeah.
That's good to hear. That's reassuring. I just, maybe sledding's not built in as such a built-in reflex. I want to make sure you're doing it safely when you get the opportunity to do it.
Yeah, we're not experts in Arkansas, okay? So we got to figure it out as we go. Not like you Michiganders. But I am very excited, and I think you probably are too, for our guest today, who is a very famous, I think you could say famous, doctor.
Absolutely. Yeah.
He's definitely one of the most famous doctors I kind of know, besides you, of course, Ned.
And IU.
I don't think that's true. But yeah, I mean, somebody that I think what's interesting about him, not only is he a social media influencer as a doctor, he also very much speaks about kind of hot topic issues, both clinically and kind of policy wise from a doctor's perspective, and is very engaging. Not he doesn't really shy from some of these topics, which I think is admirable.
Yeah.
And he's funny. That doesn't hurt.
And that's tough to do. Tough to be bringing up things like healthcare policy, COVID vaccines, emergency response networks, gastroenterology, and find humor in all of it. So I'm very excited to talk to our incredibly famous guest, Dr. Ben Schmidt.
Welcome to the podcast, Dr. Benjamin Schmidt. Dr. Schmidt is a board-certified gastroenterologist practicing in St. Louis. He also makes educational and comedic social media content under the name Doc Schmidt. With his videos, he aims to educate about the healthcare system, medical training, and the world of GI. His videos on YouTube, TikTok, and Instagram have hundreds of millions of views and have helped him gain over 1.3 million followers in total. Both in the office and online, Dr. Schmidt's goal is to educate the public about GI conditions and colon cancer screening, humanize doctors, and hopefully make people laugh along the way. Dr. Schmidt, welcome to the podcast.
Thank you so much for having me. Very excited to be here.
We probably should start off and get this out of the way, but I would love for you to walk us through how in the world you started from someone training to be a doctor to having 1.3 million followers on social media.
Absolutely. Yes. It's been a wild journey. I think I actually have COVID to thank for it to some degree, because it was a little bit of COVID boredom that started things out, because I started this in October of 2020. And I had a week off from my fellowship, my GI fellowship. And that was kind of the height of, I think, the Delta wave, when we kind of had a repeat of lockdown and everybody was obviously staying inside. I had the week off, and obviously I couldn't travel. My wife was not off, so I was stuck at home, and I I had TikTok like everybody else. I downloaded TikTok when COVID started, and I started just kind of messing around with making videos. I had the unique, I guess, advantage, maybe you could say, in that I made a lot of videos when I was in kind of middle school and high school and college. I was sort of in the YouTube generation trying to make it big on YouTube. So I had at least made skits before, but this was the first time I was like, hey, everybody else is making healthcare content. Why don't I give it a try? I've got this week of hanging around at home. So I made like 3 or 4 TikToks a day, just messing around. And from there, 1 or 2 of the videos started slowly going viral. And then I just got excited about that and kind of excited about being able to educate and entertain people. And here we are 4 years later.
That's amazing. How long did it take for you to continue doing this when your uh, fellows or other folks you were training with started to say, "Hey, I saw you on TikTok," or were you telling people, "Hey, check out my TikTok, look at this video"? How did that come about?
That's a good question. It was fairly quick that they found it. Yeah, I definitely wasn't broadcasting it. I wasn't hiding it per se, but a couple of people found me. I would say maybe 2 to 3 weeks after I had started posting. I had a video hit maybe 10,000 views on TikTok by that point. I was someone who wasn't as embarrassed by the notion just because I had been making like YouTube videos when I was younger, and I would often, share those on Facebook or wherever it may be. So I wasn't like embarrassed by the notion of it, but it's not something I was shouting from the rooftops. But I would quickly, one of my co-fellows quickly, he's kind of larger than life personality, and he would be known for, as we would walk through the hospital, if we were like getting food at the cafeteria, he would be like telling the cashier about my TikTok account. He would be telling med students while we're giving them recs, he would be telling them about my TikTok account and that they should follow me. So it's definitely something that I've been either not necessarily willingly a participant in, but definitely involved in.
So 2 weeks for your fellow or co-fellows to find out about the account. How long until a patient said they have seen you on social?
That is a good question too. I distinctly remember the one that sticks out with me the most was probably multiple months into it. I would say at least 5 or 6 months. And it was funny because it was a young woman who was very anxious about the procedure. And I think it was an EGD that we did. And after the procedure, she didn't say anything beforehand or even during. And after the procedure, she sent me an email to like the email that I had listed on my Doc Schmidt page, just saying, "Hey, I think this was you. I appreciate you doing my procedure. Hope this isn't weird," or something like that. So it was sort of an after the fact recognition, which is kind of unusual, but it was very fun.
And does that happen a lot now? Like, do patients bring up videos?
Now kind of there's the unfair advantage because now I'm done with fellowship. I'm working in a private practice office here in St. Louis. So now obviously patients quickly or frequently Google me beforehand. So it comes up pretty easily, and I don't hide it either. It's listed on my bio on the page for the organization that I work for, that I make, educational and comedic videos. So I would say probably 1 or 2 patients a day. And it's always, you can always tell by the personality how they bring it up. The classic opening is like, "I'm surprised you're not wearing a wig," is the kind of the jokester type people and I'll have to play along, versus people just being like, "I looked you up on TikTok," that kind of thing. So it's fun. I think it humanizes me a little bit. Hopefully it makes, I mean, I know some people might think it's not professional, but I think what it does is that it helps people see what I'm going to be like, not just look at a picture of me, what I'm going to look like, but they can know what I sound like, how I talk, how I interact with people, and hopefully put them at ease a little bit before it starts.
Well, I've had a similar experience in the fact that I didn't have videos, but I have had multiple patients. This is true, and Ned's gonna love this, and I'm mocking myself on a podcast. But I've had multiple patients that walk in the room like, "Whoa!" I'm like, "Hey, I'm Dr. Turpins." I'm like, "You're a lot thinner in person." It's because I have a big head. But either way, I at least that's my first impression. Yours is much better. But one thing I do like about your videos, and Ned and I have talked about this, is specifically you don't shy away from some of these hot button topics that are affecting, doctors and other folks in healthcare, and you engage, I think, in a professional way with folks that maybe I probably wouldn't be interacting with normally. And so I guess the question I have for you is what are some of the common misconceptions that you run into about doctors, and what do you experience on social media when you interact with these folks that have these misconceptions about doctors?
Oh, sure. I mean, there's misconceptions of all types, just in the sense of like misinformation and like kind of scientific knowledge, in the sense of like vaccine related things, COVID related things. But in terms of just how doctors are, I think people don't understand some of the more, I guess, famous ones are people don't understand medical training in the sense of how long medical training can be, and kind of at what point doctors are doctors and not students anymore, when they start making a real salary versus when they start making the kind of stereotypical doctor salary, where people don't think doctors should complain about things in the sense of, working 24-hour shifts or working 80-hour weeks because they're making so much money, for example, whereas people don't realize that doctors aren't even making minimum wage by some calculations, depending on how many hours that they're working, if they're in their residency or fellowship training. So that's just kind of literal, recommendations and or literal education about how the healthcare system works. And then I think that there's the new wave of kind of, unfortunately, not trusting doctors, and the fear of like big pharma and the influence that the pharmaceutical industry has in healthcare. So I think that's kind of a newer one, as there's, especially with like TikTok Shop becoming so popular, there's so many supplements being pushed, and people, it's a very common opening line on these TikTok Shop videos where people are like, "This is what your doctor doesn't want you to know about," or like, "This wasn't taught in medical school," or "They don't let doctors tell you this." So that sort of gatekeeping that is not true at all and doesn't really make any sense. Especially as a doctor, like I recommend supplements like fiber supplements every day, multiple times a day. So I think educating about that, and sometimes you do get people that are surprised where I'm like, yeah, I would gladly have you never come back if it means you're healthy. I'm not giving you fake medicines to string you along. I'm not giving you partial cures to just have you keep seeing me. I want people to get better. I try as much as I can to not give people medicines, or not do procedures if they're not needed.
Yeah, I have that same conversation a lot here. The thing I've gotten here recently is how much of a bonus I get for giving vaccines. Like the concept was like I'm paid by vaccine I give, and I just had to try to share how that works in healthcare system. And actually, clinics lose money generally on vaccines, and same thing, like I would rather not do anything. It would be great if I didn't have to prescribe a single medicine ever, and I would happily do that, but sometimes we have to. And I think just hearing it from a doctor's perspective really builds some of that trust. And hopefully, I mean, maybe this is wishful thinking, over the next few years, the distrust starts to shift back as they have these authentic conversations with their specialists. I don't know. I don't know what you see in your private practice.
Yeah, I mean, I think there's definitely people I see. Obviously, there's the anonymity of social media makes people a lot more aggressive or negative in their interactions with me than I think in person. But I mean, I had some borderline hostile interactions about COVID vaccines in fellowship. I remember, with people bringing up nonsense arguments that are just inaccurate. Um, where I think, and obviously it's not productive to approach that with hostility, which is what I try to, both online and in person, as much as possible. But yeah, I think that the discussion is naturally going to be a much more humane one, a much more civil one, if you are in person and you're able to kind of just explain things. It doesn't, like I said, it doesn't come up for me quite as often, because obviously if people are seeking out medical care in my office, they're open to that. But I've talked to, for instance, I had a young patient with ulcerative colitis who I just talked to in the last couple of weeks, who had gotten frustrated with, he had been on Humira, Entyvio, all of these different medicines, and he got frustrated with it and went off of everything and actually had no symptoms for 2 years despite not taking any of these medicines. But now he was coming back to me because his symptoms had come back after 2 years. And he was clearly reluctant to go back on a new biologic or some sort of ulcerative colitis medicine. But kind of by not just antagonizing him and telling him that that was stupid to go off of medicine for 2 years, just to get an idea of why he did that and understand that, but then say, I do think we should go back on medicines, just based off of my training and what I've experienced and the symptoms you're having. And that's what we did. And we're getting him started on a new medicine now.
That's great. I you engage with a lot of different populations, both online and in your clinic, and have lots of questions. Obviously, you're very educated. One thing I was curious on is how do you handle it when patients come to you with a self-diagnosis, something they looked up online, or now with AI, they kind of type in their symptoms and it spits out something. How do you handle that?
Yeah, that's becoming very common. I think that it's usually, I mean, honestly, the literal answer is I usually say that could be. I think like when they first bring it up, like because it could, I think that's the most important thing is to give some level of validation, but so that they don't feel antagonized from the get go. Um, so, because a lot of times people come in and they've been diagnosed with something by a different GI doctor, even, but it was like 20 years ago, and they're not sure. Like they're like, I was told I have IBS, and I'm like, yeah, that could be. And that's usually how I start, so that they feel like I'm listening to them. And then we kind of just delve into what that disease is, what it means. There's some diseases in the GI realm that are even more controversial in the sense that it's controversial as to whether they even exist at all. So, like leaky gut is one that's very famous, or small intestine fungal overgrowth, or candida overgrowth in the intestine. So those are ones where it's a little bit trickier, where I kind of acknowledge that. I'm like, now these are things where theoretically it kind of makes sense, but there's not much evidence to support that they exist as their own entity. They might more just be side effects or symptoms of other diseases. And I think just giving some credence to whatever they're bringing to the table is important, so that they know you're on their side. But then kind of bring in your own experiences, both in the sense of what you've seen as a doctor, the patients I've scoped, the patients I've treated, as well as what I've learned in my lectures as a GI fellow, and my experience as a GI fellow, and working with attendings who have far more experience than me, that we haven't seen this before, but new diagnoses are found every year. So let's kind of approach this one step at a time, see what's been looked at before, and see what tests we can still do to get an answer for you.
But I want to ask. So I don't do outpatient medicine. So full transparency here. It's been 1 year about since we've really noticed like a leveling up of like the AI models that exist, like that are publicly accessible. Do you see better self-diagnoses yet?
I don't know. I don't know that I've had enough, patience to really conclude that. I would say that probably there are a lot of people that are coming with IBS when IBS is actually a reasonable diagnosis in their case. So I guess in that sense, yes, there is more self-diagnosis of IBS specifically. There's a lot of GI diseases that have very famous buzzwords, I guess, in the sense of like, an ulcer is like pain in the middle, and then gallbladder is, right upper quadrant pain. So in that sense, there's always some level of reliability, at least in the sense of like the most likely diagnosis. Since I'm in private practice now, I'm doing a lot of like, I'm the first GI they've ever seen. So I have an unfair advantage of the obvious things haven't been looked for yet because they haven't seen a doctor for this issue. So I might not be the best person to ask, but I would say, yeah, a lot of times patients do have um, a reasonable idea of what's going on. There's still the people that are scared of cancer, but not unreasonably so.
I've had patients show me the output on ChatGPT, and it's like we'll talk through it. And I love ChatGPT. It's not an official endorsement; they haven't paid me to say that. But and it's nice though to talk with them how it works, and it has definitely changed, at least from what I've seen in primary care, which is obviously a little bit different than Ben's situation. I did want to ask one thing, and then I know I promised that I'll let you ask some questions. But you've already mentioned your training and then going into private practice. I'm curious, what do you miss about residency or fellowship training?
Well, I definitely don't miss being the third or the fourth opinion of a patient with undiagnosable GI issues. So that's the first thing that comes to mind. But in terms of things that I miss, I mean, certainly the camaraderie of being in a fellowship or a training program in general is really fun. Just being able to having so many people that you can either bounce ideas off of, or help each other out if someone's sick, if someone's getting destroyed with a million consults. So that kind of camaraderie. I mean, I still have that to some extent in private practice. I have three other physician partners and then three nurse practitioners I work with. So we do discuss cases, certainly, but it's obviously a little bit different when you're all coming from different backgrounds and you're all have a little bit of a different schedule and approach to work compared to like a true training program. So I would say that's probably the most memorable, just because there's so many wild things that you see in training compared to in private practice, at least in my 1.5 years of experience in private practice. It's that kind of camaraderie for sure for me.
The thing I always hear about is just it's more parallel play in the attending land.
Hmm.
I'm stealing a pediatrics term, but it is, yeah, you do obviously want to communicate, but it's not the same when you're stuck inside the hospital with a group of people for years, which sounds terrible the way I phrase it, but it's kind of that's kind of
Yeah.
what it is. Uh, there you go, exactly. Well, I'll shut up, Ned. I know you have a million questions too for a bit.
Eating the same string cheese together every single day because somebody stole a box from the cafeteria or something along those lines. So
A lot of string cheese.
a lot of string cheese, a lot of string cheese. As I'm sure my nutrition, I should probably see a GI doc for as much as I survived off of it then. So I mean, sticking with residency for a bit, if it just, and this is more of like on the fun side of things, like if you had to give an honest review of medical training, like a Yelp review, what would it say?
There's yeah, the stereotypical, the days are long but the years are short, I think is a apt description, in that you can have brutal shifts or brutal, days where they just seem to go on forever, but it does seem to go by very quickly. I would say it's a time where you will learn more than you ever thought you could learn in a given time interval, be that in a year, in a 3-year training, or even in a single day. It's something that I never want to do again, but I'm glad that I've done it, I guess, is another way, another phrase I guess you could
Yeah,
use for it. You
a surprisingly fun thing I'll never do again, or something along those
yeah,
lines. I think I stole that from
exactly.
Dave Eggers, so I should quote that correctly.
Yeah. 10 out of 10 would not do again, I think, maybe.
Would not do again. Exactly. Any difference between residency and fellowship with that?
Yeah, definitely. I mean, fellowship is a very different animal, for a lot of reasons. Fellowship is a lot more responsibility and stress in the beginning, because I kind of make the joke a lot. Like, no one expects a medical intern to be able to help them, but everybody expects a day one GI fellow to
Yeah,
help them
yeah.
immediately without any hesitation. So that's very stressful. So it's honestly, I thought it was a steeper learning curve for that reason, just because the expectations are higher. Obviously, a lot more medicine, as of going into fellowship, so how to manage a patient in general. But in terms of what you're actually learning in the fellowship, like when to scope, how to scope, these things are much more challenging. So GI fellowship in particular, for me, because you're like learning a skill, that's the honestly probably the biggest component of GI fellowship, is learning how to do the colonoscopies and the upper endoscopies. I found it in some ways more frustrating because it's a skill that's hard to learn, obviously. So there's a lot more failure in the more traditional sense, in the sense of like, you could not get to the cecum, you could not take out this polyp successfully, and someone took the scope from you and did it instead. Whereas in internal medicine, it's like you didn't diagnose it correctly, but then your senior resident just helped you out, and then you learn. It's a lot more nebulous in internal medicine, but a lot less busy fellowship. You feel like a lot more of a person at the same time. I felt more like it was a job, as opposed to that my life had been taken over, which is what residency was more aptly described as, at least in my experience.
Yeah, the shifting responsibility is fascinating, right? Like I love that idea of I've called July 1 fellows and been like, sorry, we need help.
Yeah.
Like we need
Right.
your expertise here. And they're like, I know what you know.
It's the same.
It is the same. So, so you've been practicing now for about a year and a half, 2 years, right? You graduated about
Mhm.
this will be your second year out. What,
Exactly.
yeah, what have you seen that's changed the most drastically since you started?
In terms of about like GI or about myself?
Yeah, medicine and GI. Yeah.
Well, I mean, I guess my lens is a little bit distorted just because I'm so in tune with social media, but I feel like the frustration with insurance companies has magnified dramatically, obviously with recent events, but just in a general sense, I think patients are more aware of how insurance companies are a mess, and I think doctors are more open about it with their patients. So I think that trying to like deal with insurance and prior authorizations and that sort of thing has become much more of a public outcry. I would say awareness about colon cancer, I think, has improved. I think that's been a kind of a positive spot where more and more people are coming in. They're asking about that prophylactically. That's not the right word. They're asking about it, before they're even 45, just trying to like plan ahead, or like if they should be screened. So I feel like that obviously a year and a half is a small time window to really notice big changes, but I think that's a trend for sure.
Can I ask, this one's is very still with GI, and then I want to, we want to head back to the social media aspect of your life and career. But within GI, like I see a lot of headlines, questionably scientific headlines, about the rise in colon cancer in younger people. Is that happening? Like, talk about a thing that, like, there is evidence that supports it may be happening in certain subgroups. There's evidence that says it's not, and it's just a selection bias. Like, I've got an opportunity to ask an expert here. So I want to know. And if this is too hot, tell me if we can. Yeah.
Well, I mean, I guess I must admit, I mean, the data that the best data we have is the data that kind of led to the lowering of the age from 50 to 45 in terms of screening. And I think that we're compiling more data now to decide if maybe in the future we'll even have to lower it to 40. I do anticipate that. I don't necessarily have evidence of that, so to speak, but I wouldn't be surprised if we at some point have to lower further. And I think the concern is the diet and the environmental factors that are playing such a big role in a lot of elements of the healthcare system,
Mm-hmm.
and just the kind of metabolic syndrome, inflammatory syndrome that we're learning about that causes, fatty liver and NASH and all these sorts of things that are maybe playing into it. So I do think that it's legitimate. I mean, anecdotally, I have multiple cases of this, which obviously we don't want to lean on that, but definitely, 33-year-old with colon cancer was having symptoms, that kind of thing. Or a 45-year-old came in for the routine screening and she had an obstructing sigmoid colon cancer kind of thing. So, I mean, anecdotally, it's a thing. Obviously, that's not enough to raise alarm bells, but it's something that we are definitely seeing younger and younger people having issues, even though we've lowered the age already. So I think it's something, a sign of change that needs to be made from a public health kind of systemic standpoint.
Yeah, and I wonder if, piggybacking off what you said, like, people are more in tune with their insurance and more in tune, I think, with their barriers to care. So I do wonder, like, how much are we seeing some of this as a result of, like, delayed, deferred care, like you said? I know that you've got anecdotal cases. We've all got anecdotal cases, totaling in the probably thousands between the three of us, of people who willingly or willfully delayed care because they couldn't afford it, they didn't understand it, they just, the just low literacy, and then frankly just this perception of the insurance company's not going to pay for it anyways. I hear that all the time from the inpatient setting of, like, I didn't come, they weren't going to pay for it. Like, well, we don't really know that until I get that it's a little insane. You don't know if they're going to pay for it until you've already gotten it. But, like, oh no, it's so late now. There's so little.
Right.
So it's very challenging. I think the intersection of those two pieces, right? Of, like, there is a rising concern with environmental and, of course, nutritional factors and food quality, safety, things like that, against, I think, healthcare that's gotten more challenging to access as a result of COVID over the last 4 years.
Yeah, no, I think it's sad but true.
Mm-hmm.
Can I ask a clinical question, Ned? I'm interrupting you. I'm really sorry. Is I can see your face is very happy. Is the I get questions about this. I'm curious on what you say, Ben. Like, on the recent study, I can't remember when it was, 22 or 23, that about screening colonoscopies for colon cancer, and it's maybe less than impressive impact on mortality from colon cancer. How do you answer questions from patients who have, they kind of question, do I really need to be doing this? It didn't really reduce mortality in this headline I saw on, Twitter or something.
Yeah. Are you referring to that one that it was like in Europe? It was like Northern Europe country. Yeah, no, I actually haven't had a patient directly ask me about it. I've had colleagues ask me about it before. I actually made a video about it too, along when it came out, talking about it, because there are some problems with that study, in the sense that it's been so long since I've thought about it. But a big one that I remember for sure is that the adenoma detection rates of the doctors, which is like the rate at which these doctors found polyps in the people that they were doing the colonoscopies on, was much lower than the accepted rate. So the thought was that either these doctors aren't as experienced, because in Europe they don't do colonoscopies quite as often. But there were multiple, the other two, I remember at least one or two other points that I must admit are escaping me now, but there were 2 or 3 salient points that made it not as representative to American medicine or to the United States system. So obviously I'm biased, but based off of that, and it was the ACG, the American College of Gastroenterology, had a similar kind of statement, is that we don't think that this study is sufficiently, powered or sufficiently representative to alter the recommendations of colon cancer screening.
Yeah, that's kind of been my answer too to the people who've asked, is it was done in a different place and designed a little bit differently than how we do screenings. But maybe I saw your video. Maybe you're the one who actually educated me on that. I appreciate that. Sorry, Ned.
No. It's a great question. We're obviously just both peppering you with questions to be better clinicians. So to take this back to our practice is really what we use this podcast for, is to try to be better doctors. So have some fun doing it. So
exactly. Love it.
I was going to ask now, just for some, just kind of getting into some fun ones. I want you to put on your omnipotent hat here. And if there's one thing you could banish from modern healthcare forever, what would it be and why?
Well, depending on how serious you want to be, the first thing that comes to mind is doing FOBT, stool blood tests on admitted ER patients to assess for a GI bleed, because that's not how they're supposed to be used. For people who aren't as familiar, that's a test where you test to see if there's blood in the stool, which intuitively you would think would be the perfect thing to do if you're seeing a patient who you're trying to figure out if they're having a GI bleed. But the problem is those tests are more designed for occult GI bleeding, meaning blood that you can't see. And that is a great indicator that someone needs a colonoscopy to look for colon cancer, or to look for some lesion that might have been missed otherwise, to find that problem. But if someone comes into the hospital saying they're having a GI bleed, seeing GI bleed, the only determination of whether that patient needs to be scoped is related to whether they are seeing blood or they're having melena, black stool. It doesn't matter if their FOBT is positive, their stool test. So that's a very selfish one. The unselfish one, that now that I've been talking and realizing that's a really selfish thing to say, is related to insurance companies and just the prior authorization process and how that works. It's in GI, we experience that profoundly with biologics, the medicines that we use for Crohn's disease and ulcerative colitis, the amount of trouble we have getting them approved, and then insurance companies just deciding on a whim that they're not going to cover that one after we've approved it and had the patient successfully be on it for 6 months, and then they're like, oh, actually, you can't give them this one anymore. So it's not only tiresome and wasting man hours, but it can, and sometimes literally cause negative outcomes. I have a patient who was on Humira, and they told us we had to switch him to a biosimilar, as it's called, which in theory should be the same as Humira, but it's a different medicine. And he had a flare within 3 weeks of switching that medication.
The prior auth, I think, is one where a lot of people in our audience would ride with you to to remove that. Especially in your world, I hadn't thought of it in the realm of biologics. It's not class, but like biosimilar is not the same. It's kind of shocking to me that that's included in the same conversation about, like, oh, can you give generic or brand name? Like, that's the same drug. Like, the same is not similar, like,
right, by definition.
Yeah, like, I have a brother. He looks similar to me. We are not the same person. So,
Exactly.
okay, I very much appreciate that one. Thank you for. I mean, honestly, I could do away with the FOB too. I understand that one's a little more selfish and directed towards your own practice, but I think that's still one
Exactly.
people would be on board with.
Sure.
I know this is a hot button topic, but how do you feel? Or I guess first of all, by the time this comes out, it will already maybe have in effect been completed. So this is an obsolete question, but the TikTok ban, like, how do you feel about this upcoming? And maybe, as I said, it's already out and banned by the time this episode's out. How do you feel about that? How's that going to affect you?
Well, it's funny you say that, because during the time of us filming this, I actually have posted a video about the TikTok ban and my thoughts on it. So people should definitely go check that out. But what I say in that video is a couple of things. But actually, the title of the video is the TikTok ban actually a good thing? And the reason, it's a little bit of a clickbaity title, admittedly, but the reason and kind of my thesis in the video is that I think in some ways it's good for TikTok to be banned, very specifically in my case, because that means TikTok Shop is gone. And I have a lot of problems with TikTok Shop specifically. So I think overall, obviously, there's a lot of problems with TikTok being banned and why it's being banned for the wrong reasons and those sorts of things, and freedom of speech and those elements. But I think that the one positive that would come from it being banned is that TikTok Shop is no longer a thing. I've recently made multiple videos about things that I've seen on TikTok Shop, namely supplements. The healthcare side of TikTok Shop is very problematic in that there's so many non-healthcare people that are simply pushing these random supplements, trying to get commissions on them, and using confusing terminology, using wrong facts to trick people into taking things that are most likely just not doing anything, but could be dangerous. And that's a huge issue. There's people for diseases that don't exist or that already have better treatments, parasite cleanses, liver cleanses, things you don't need, trying to trick people by naming. There's a whole liver supplement series that I did where they try to use very vague symptoms like, do you have fatigue, do you have bloating, then you might have liver disease. Well, it's like everybody has either fatigue or bloating or occasional belly pain, so I think that it's just become this epidemic of scammers, basically, where I made this video, for example, of this guy who, you watch this one video and it's very intriguing, and it's him, he's in scrubs and a mask, and he's walking to his car from a hospital parking lot. He's like, I just got fired from my job for trying to help a patient. I was telling them about this way to help with sinus congestion, and my boss overheard and I got fired. And I was like, that's bizarre. So I went to see what if he was a nurse or if he was a tech or what. And I very quickly saw that he has dozens of videos, all with the exact same script for a different healthcare product. He's like, I just got fired from my job at the dentist's office for trying to tell a patient about these cavity cures. I just got fired from my job at the ICU for trying to talk about this infection cure. It's a parasite cleanse, but literally verbatim, the script is the same in every video. He just got fired from all these jobs within days of each other. And it's just, I think we'll be better off without that, I guess, is my biggest takeaway. I do think it's unfortunate financially. I mean, I make some money from TikTok, so selfishly, I will miss that. But I definitely think that, honestly, in some ways, maybe the bad of TikTok Shop outweighs the other elements for me.
So maybe a net positive for society. It's interesting. Do you find, I guess, the platforms, I mean, are those people you think going to shift over to like YouTube Shorts or Instagram? I mean, like that's where they're going to go somewhere else for their fix, I guess.
Correct. But I think, and I talk about this in the video, I think that TikTok, in the same way that TikTok is special in the sense of like a nobody can become viral and can get discovered. But the problem is that applies to the TikTok Shop as well. So I think it's a lot easier to reach a lot of people very quickly. And then for those people to very easily buy that thing is the other thing. Like you can literally buy it within TikTok, as opposed to if it's on YouTube, it's like click the link in my bio and then you go there. Obviously, yes, they can still do it. There were supplement scams before TikTok and there will be after, but I think TikTok made it worse.
And this is a dumb question. Instagram, you can't do that either. There's ways to shop in Instagram, I thought too, but is it not the same?
I don't believe it's as extensive Instagram Shop. I think Instagram Shop is more an easier way to like link to products. I don't like, whereas TikTok Shop, it's like an Amazon platform within the app, which I don't think Instagram Shop is like that. But I must admit, I don't know either.
I hope they don't go that route. Like, I hope they don't see that as a hole in the market and try to
Right.
fill it. Yeah. Particularly scary flavor.
And that's the thing I talk about with patients is like the accountability piece is the reading between the lines of what you said about these folks. The lack of accountability is the frustrating piece. Whereas all three of us on this call have a lot of accountability built in place for what we recommend or do not recommend. You can just be anybody and go on TikTok and push a supplement and say things that aren't true, and you never face any accountability.
Oh yeah. I mean, it's just crazy the things that I've seen people say. I had a guy saying that I can't even remember the details, but saying that something would put that like a imbalanced gut microbiome could put holes in your colon, for example. Just like completely nonsense.
Oh my.
No accountability. Yeah.
I might have some holes.
So I might, honestly, I've got a little bit of belly pain and bloating. I feel like I'm full of holes here, Ben. I think I will say, you mentioned it earlier, and it just, I see it all the time, and it's one of my favorite, truly like nonsensical sales pitches when you peel it back, of like, they don't teach this in med school. And you're like, yeah, it's nonsense. There's no substance here. We completely agree. This is a weird
Yeah,
scenario where I'm completely in agreement with this snake oil salesperson selling nutraceuticals or something.
but it sounds so appealing. You're like, oh wait, why don't they talk about it?
Oh yeah, yeah, yeah. The conspiratorial side, yeah.
A couple, just zooming out a little bit, just on the occupation, and then we'll kind of close out here in a minute. But I ask this question a lot of other fellow doctors, and is would you choose this path again, if looking back on it,
GI specifically, or just medicine?
or just being a doctor first? But yeah, GI then as a subsequent question.
Yeah, I mean, I think the way I usually answer that question, I wouldn't like if somehow I accidentally time traveled back with my current knowledge and experiences, I would not do it again because I couldn't go through it all again. But I would recommend to my younger self to still do it, I guess, if that makes sense. So if I was the one, my mind and my body that would have to do it, I don't think I'd be able to just because it is such a grueling process and all the steps that led to getting here. I just it's a tough road. So I don't think that should be undersold. But I think the end of the road is worth it, at least in the experiences that I've had at the end of that road. So if I was giving advice to my 15-year-old self, I would still recommend he do it again.
And if you weren't a doctor, what do you think you'd be doing?
Hmm. I mean, I my second choice was being some sort of film director personally. So that's why I'm pretty happy with where I've stumbled upon in this little niche of social media. Because yeah, I actually wrote one of my I still remember this. I wrote an essay applying to I think it was Emory's medical school, and I talked about how I made this whole analogy about how like directing movies is like being a doctor. And I had my mom read it, and she was like, "This kind of reads like you want to be a director rather than a doctor, so you might want to do something different." And I rewrote the whole essay.
Oh, so they didn't actually see it.
No, they never saw it. I was like, "Yeah, that's a good point."
But
That makes sense. Well, if your medical school self could see you now, what do you think they would say? I mean, I guess it's totally unpredictable where you wound up to a degree, but
Yeah, I mean, well, yeah, obviously the social media side, it would be, utter shock and awe and excitement. Because that is, I'm a little bit unique in that I kind of always had that desire. I wanted to be famous on YouTube before I was a doctor. So that's kind of a very fun, come to fruition moment. But in terms of like where I am with my practice, I think the med student in me would be very kind of proud and excited because that was when I started being interested in GI. So I think it would be cool for him to see the journey is worth it and has a successful end.
yeah, and to see like maybe it's nice to have a few extra seconds in a TikTok than say a Vine, where that was the shortest
Right.
video we had. For those of you in the audience that know it.
I did make a few vines. Yeah.
7 seconds, right? Yeah, wasn't that the cap on it? Yeah,
Very limited.
tough to educate in 7 seconds.
You were forced to be really creative. Yeah, I mean it was very interesting. Here's a question for you. If medical specialties were high school cliques, like the jocks, the nerds, the class clowns, who would GI be?
I think, well, I mean, I feel like they say that GI is kind of like the jocks of medicine specialties. Like, not obviously, we're not jocks like ortho, like, but like we don't like there's some less nuance. So maybe we'd be like the nerdy jocks, if that's a thing, like the nerds who play sports kind of thing, maybe.
I like that. GI are the nerds who play sports. And the internists that don't become GI docs, they're just the nerds.
They're just, yeah, and then yeah, because you can kind of branch out, like because infectious disease, I feel like is nerdier nerds,
Yeah,
and then GI is like going towards the jock way a little bit,
yeah.
and like
We're med peds. What's med peds then?
med peds is just the straight and narrow perfect kid.
Wow. Wow. That is
For
I
sure.
think nice.
That may be the nicest thing. I don't think it describes either of us in our scholastic endeavors, but it's that may be the nicest way. Like I get what you're going for though. It's the kid who's like proud of having like zero tardinesses. And like,
Yeah,
you
yeah.
know,
He just does. He follows the rules. He does what's expected of him, and he excels.
yeah, 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 yeah. He's equally likely to be found at a Dungeons and Dragons table and at like a ribbon dancing festival. Pretty equal parts.
I
Right.
guess it makes sense that both of those sound kind of fun,
Fun, yeah.
or both at the same time.
They're appealing.
People ask me this all the time, but is there any medical theme sitcom or TV show that's tolerable to you?
Oh yeah, I mean, I'm very unique in that I think House is great. I love watching House. I personally do not understand the problem that people have with House, where they're like, "Oh, he does everything." It's like, what do you want this show to be? Like, I don't understand. Like, you want to watch random groups of people that you don't know doing the labs? It's like it's just a vehicle for telling the story. Let them do the labs themselves, please. Yeah, I love House.
Hey, we need a film director to come on here and just like judge. Maybe we do a whole separate podcast of just Ben judges medical shows with your film
That would
director
be
hat on.
awesome. I have a lot of opinions on them.
I've had people talk about The Resident. I've never seen that either, but it just seems like too too close for me to want to watch it, and I would just be annoyed. I don't know if you've seen that.
Correct. No, I've never seen it. I just learned that it's based off of a book about like
Oh,
because there Marty McCary wrote a book about written a lot of medical books, but he wrote this book about like how doctors make mistakes, and like it's called like unaccountable or something like that. And apparently this show is based off of that. I have no knowledge of the show other than the trailer I've seen. But I didn't realize that. And then there's a new show that just came out, at least as of us recording this in the last week on HBO called The Pit, which is supposed to be like kind of like an ER reboot vibes.
with Noah Wiley again. I think it
Yeah,
brought
right.
back. Yeah, right. I started to see a bunch of ads for that. It cracked me up. I watched about 5 minutes of The Resident, and I was like, everybody's well slept and attractive. Like I don't like
Yeah.
everybody looks great.
There's not enough scenes of people just writing discharge summaries.
Like, yes.
Exactly. Unrealistic.
Totally unrealistic.
In like a yellowed white coat, like because it's just been dragging on things. Like, yeah, they missed some of that really thick patina that lived on all of us for several years. So,
Doc Schmidt, I had one last question for you. And we asked this to all of our guests, and we'll close out here. But tell us one thing that you've changed your mind about recently. We ingest lots of data, maybe more data than ever as human beings. But the premise is, do we use that data to just reinforce what we already believe, or has there been anything recently that you've actually substantively changed your mind on?
Hmm. You mean in the sense of like changing my medical practice and how I do things?
Could be medical practice or an opinion that's non-clinical or medical related.
Interesting. I think, well, the reason that I brought up Marty McCary is because I just read a book of his about blind spot. It's called Blind
Yeah.
Spots, about things that doctors have gotten wrong in the past, talking about kind of famous things like the peanut allergy issue, where we thought it was good to avoid peanuts, but then it showed that actually increased peanut allergies, and just different things throughout medicine. So maybe this is a little bit of a cop out, but I think that since I've read it so recently, I haven't had a chance to fully use it, I guess. But for me, it sort of depressed me a little bit in the sense where I'm like, nothing is real. What am I even doing? These things that, we think are standard of care are potentially just completely wrong. So for me, I guess it's trying to not just do what I was taught in fellowship and look up things more consistently, in the sense of my only reason for doing something shouldn't be just because that's what they did in fellowship. So I haven't had a concrete example of that come up yet, because I literally finished the book like 4 days ago. But my goal for using it is to try to be more objective and pulling off of data rather than my just past experiences, and then try to use that.
Yeah, makes sense. I've heard interesting things about that book. I've not read it, but I need to.
Yes, it is controversial. It starts in a much less controversial way and then uses that trust to make some controversial points, which we don't have to get into. But it is, I think it's worth a read for sure. And apparently he's going to be the director of the FDA in Trump's administration.
I saw that.
So,
oh, okay. I know who this. Yeah. All right, I'm caught up now. I think, look, in many ways too, I totally understand that, that feeling of that, like, oh God, like, what are we doing? What are we doing?
Right.
What are we doing? Nothing is
Yeah, right.
real. At
Yeah.
least not two of the three of us are recommending Marlboros. And like, so there's like, I always have like some, like, I feel like we're at least standing on the shoulders of a great deal of science and good thought, though. That often helps me when I slink into these like crippling ennuis. Frankly, especially, and I'll speak to it, especially in pediatrics. I don't know if Michael, you still feel this, like, far less data driven and far more expert opinion driven. And especially when you get into like novel or esoteric diseases, there's, maybe 6 people in the country that treat these certain things. You're like, oh, do this. You're like, oh, okay, I don't like this at all. So it comes up unfortunately, pretty frequently. I don't know if Michael, you still get that quite a bit, but
No, I mean, it's funny you say that. You brought up the peanut thing, right? I mean, talk
yeah,
about not being data driven. And Pete's were like, let's be data driven about this thing. And they did the study and like, actually, this is wrong.
found out we're exactly wrong. Yeah. We're never
No.
using data again. We hate this feeling.
That's right.
Didn't work
That's
at
right.
all.
This has been great. I know you're a busy man, so we will let you go. But I was gonna see for our audience, educate them on where they can find you online.
Yeah, no, absolutely. So I have uh, platforms across most of the big social media platforms. So on YouTube as Doc Schmidt, on Instagram, Doc Schmidt IG, on X or Twitter, Schmidt Doc. And then if TikTok is still around, Doc Schmidt. And then my website is docschmidt.org, where I have some of my favorite videos and some educational tidbits for patients and for providers. And if you like fun, silly children's books, I have a children's book called The Night Before Med School that is available on Amazon.
That is amazing. I didn't realize the book. We're definitely going to promote that. I love that.
We got to re-record your bio now. Go back to the beginning. I mean, published children's book author, Doc Schmidt. This is incredible.
Congrats. That's so cool. That's so cool.
Thank you. Yeah, so it's a little project I did, adapted one of my videos into a book, basically about 2 years ago at this point.
Well, Doc Schmidt, thank you so much for taking time out of your busy schedule to join us today.
Yeah, of course.
It was very, very fun. So I appreciate you. I'm sure we'll talk soon.
Thank you. Yeah, it was great, guys. Thanks for having me on. Good to see you again.
Thank you. Good to see you.
Thank you for joining us on another episode of the podcast for doctors by doctors. You can catch us on Apple, Spotify, YouTube, and all the other major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. As always, thanks for listening. And the next time you see a doctor, maybe you should prescribe this podcast. See you next time.